And welcome to the Dr. Bob Show. You know, I'm always amazed at the new advances in medicine, advances in treating heart disease, advances in treating kidney disease, advances in the treatment of diabetes, advances in the treatment of lung disease. We'll be spending most of this show talking about brand new findings and new treatments that are available for bronchial asthma, a condition that occurs in 25 to 30 million people in the United States, and these new treatments could be saving lives. My guest is Dr. Phil Jones. Dr. Jones is a board-certified pulmonologist, lung specialist, and board-certified allergist. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we're going to be talking about what we can do to prevent dementia, that difficulty thinking, cognitive problems, and who needs a flu shot? Do we really need a flu shot? And if so, why? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Phil Jones, board-certified pulmonologist, lung specialist, and board-certified allergist. We're going to be talking about recent changes in the diagnosis and treatment of asthma. Phil, welcome to the Dr. Bob Show.
Thanks for having me. Glad to be here.
First of all, what is asthma?
That's a great question, and it's not so easy to answer. We used to think of asthma as a disease. You know, a disease kind of has the same presentation in patient after patient. But it's really a syndrome. At least that's my opinion. There's so many different ways it can present and act in different patients. But there are some common features: cough, breathlessness, chest tightness, wheezing, nighttime awakenings, these type things.
So these are symptoms that people have that have asthma. So let's talk about some of those specifically. If somebody has bronchospasm, that's where the bronchial tree goes in, is that part of asthma?
Yes, that's kind of airway hyperresponsiveness. That airway's twitchy, and it doesn't take much for it to clamp down and make it hard for you to breathe.
So when that happens, how does the patient feel?
Tight, breathless, cough, wheezy, an elephant on the chest, those
Scared?
kind of things. Absolutely. Some of them are just scared to death, and then you're scared of that happening again.
So it really makes the patient and the family that surrounds that patient very worried about what's going to happen to their loved one.
Absolutely.
So that's bronchospasm. The other thing that we always talk about is inflammation. Now, what does inflammation mean in a lung disease?
Inflammation means instead of being a big tube that you can breathe through easily, that tube swells. So there's increasing thickness to the mucosal layer, increased secretion production, and smooth muscle hypertrophy. So instead of breathing through a garden hose, it's more like a straw.
So if you've got problems with bronchospasm and you've got inflammation, you've got some real trouble that we have to be able to treat. So some of the symptoms you said were coughing. Why do people cough?
Cough is related to some of that inflammation, but you know, cough is not just inflammation. People cough at night. Asthma tends to be a little worse at night, and some of that is a combination of things. When we lay down to sleep, we get more drainage from the sinuses. That contributes to cough. Reflux is worse at night. Asthma, there's more inflammatory cells in the lung at night than during the day. And then there's sleep apnea on top of that, which can aggravate asthma and vice versa.
So there's lots of things that can make nighttime asthma worse. We used to always say asthma is a nighttime disease. People wake up in the middle of the night with cough and wheeze and shortness of breath. What do they do for that when they wake up in the middle of the night?
Yeah, heck of a way to wake up, isn't it?
It really
Scared
is.
and short of breath. Well, most people have a rescue inhaler. A rescue inhaler is a medicine, a quick relief. I can take it and it'll open me up and I can breathe, okay? So albuterol is an example of that. All patients that have it, but I meet asthmatics all the time who don't even have a rescue inhaler or don't know how to use it properly.
And that's a big thing too, knowing how to use it. So you need to be sure that your physician instructs you. Don't say, here, take it, sort of thing.
Absolutely.
So if people wake up in the middle of the night and cough and wheeze, and they get up the next morning and they're not having any problems, they go to the doctor's office, sometimes the doctor wouldn't recognize that it's asthma and would say, well, you may have had a little anxiety attack. So it's difficult.
It is. And we see that a lot, though. You know, you see people that cough a lot, and I see this in children a lot. Cough, 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 and oh, that's allergies, or that's sinus, or it's drainage. And they eventually end up in an allergy office, and we do spirometry, which is an objective measurement of this narrowing of the airways.
So what is spirometry now? When you say that word, what do you mean?
It can be as simple as a little handheld machine that you blow into, and it's based on your age and your height and your race, and you should fall within a range, okay? And some people don't have that available in their office. Their pediatrician may not have it, their internist may not have it. And these patients show up and they've coughed for years, and their doctors have attributed it to a number of things, but we do spirometry and they've got 60% lung function or 50%. And you put them on appropriate therapy and they're sleeping through the night, they can do whatever they want to, they're not coughing, and they just think you're the greatest ever because you figured this out.
And it must be great to figure out when people have asthma and know that there are good treatments and good medicines for that.
Yes.
So cough, wheeze, short of breath, tightness in the chest. Where do the sinuses come in as far as asthma goes?
I'd hate to know how many times a day I say this, but I'd say, patients, if this isn't happy, this isn't happy. There is a direct correlation between those, and there's many patients with chronic sinus disease or allergies or both that we get that cleared up and their asthma control improves significantly. They may go from multiple medications to one or even none.
So knowing that the sinuses or the nose can be a trigger for the lungs is an important thing. If you don't treat the nose, the lungs may not get better. What are some, when we use the word triggers for asthma, what are some of the things that come in your mind? What does the word triggers of asthma mean?
Well, part of what we do when we teach an asthma patient is we want to help you identify your triggers so that we can plan ahead for maybe that fall pollen season or the spring pollen season, or maybe you like to run in that cold, dry air of winter. So we want to know, what are your triggers, okay? And so when we look at triggers, allergy is a big trigger. Okay.
So when you think of allergies, you mentioned pollen just a minute. Pollen could be one. What other allergy triggers?
Dust mites are a potent trigger for asthmatics. Cockroach in the right situation, particularly in certain populations, is a very potent trigger. And it's overlooked because not everybody tests their patients for that. They don't send them to the allergist for that test.
So how do you find out if somebody's allergic to dust or cockroaches or pollen or mold?
Yeah. Two ways to do that. The way we usually do it, which is a kind of what we consider to be the best way to do that, is a scratch test, a little plastic device with the antigen or the allergen on the skin, and within 10 or 15 minutes we'll know if it whelps up like a mosquito bite, that's an allergy. We need to avoid that. We need to talk about all the things we can do to minimize exposure to that.
So if you find a trigger by doing allergy testing, dust or pollen, how do you tell people to avoid those things? Some of those are difficult.
Yeah, pollens are exceedingly difficult. I mean, even if we're an indoor person, pollen's very difficult. But dust mites, anywhere there's dust mites. So we can't control that completely. But dust mites live off the skin we shed, so our pillow and our mattress and stuffed animals in the right situation, rich source of dust mites. So we talk about how do you take care of that. Allergen covers for the pillow and the mattress, wash your sheets once a week in hot water, monitor the humidity in the home and that type thing.
When we talk about treatment for asthma, we're going to get into some newer treatments later on. But what are the standard treatments that we have for somebody that has significant asthma?
So all asthmatics need a rescue inhaler. That's usually albuterol of some form or another. That's your quick relief. That if I have bronchospasm, smooth muscle bronchospasm, it's a quick relief, okay? But it doesn't improve asthma control. It doesn't prevent recurrent flares. It's just a patch. You can get through the day, but it's not the relief or the quality of life that you're looking for. So then we have anti-inflammatory medications.
Those controllers?
Those are controllers or maintenance medications.
And what would be some of those? And what do they do and how do they help that asthmatic?
Well, there's some that are pills. Okay, there are leukotriene receptor antagonists like Singulair. There are things like Zyflo. It's a drug. We don't use it often. Take it twice a day. has some rare liver toxicity, and we have to monitor blood levels. A lot of patients say, I don't want to do that, kind of thing. There's theophylline, been around a long time. I don't use it much, but it has anti-inflammatory properties, a very narrow therapeutic index. Have to watch blood levels and drug interactions.
Inhaled cortisone?
That is the cornerstone. I always tell patients we're going to start with a foundation, get things going, and we can add to it. We can build onto that foundation, but we need a foundation. And that foundation is the inhaled steroids.
And what does that do when we had bronchospasm and inflammation? Where do the inhaled steroids work on?
That works mostly on that inflammation, okay? And that's what leads to the narrowing and the mucus hypersecretion.
So if you can get rid of that, you get rid of the twitchy lungs, the patient does better. Can they stop the medicines? They have to be on them on a regular basis, or it's individualized?
Well, you know, I get asked that every day. Well, Dr. Johnson, am I going to have to take this the rest of my life? And I said, well, and you base that on their presentation, adult onset asthma, usually, but I always tell them, maybe. Here's what we're going to do. We're going to get you under control. Once you're controlled good for 3 or 4 months, we'll start stepping down therapy. If your lungs will let us go to off, we'll try. But I said, don't expect it.
We give some people a peak flow meter. Does that give you any information of how the patient's doing?
It can, okay? It's very effort dependent.
And that's what we're going to be talking about when we come back. A peak flow meter, what's that? How does it help you in your asthma? How does it help you know how you're doing? And what are the newest and the greatest in treatments of asthma? There are 5 or 6 new ones. A lot of information. You'll want to stay tuned. We're talking with Dr. Phil Jones, a board-certified pulmonologist, board-certified allergist. We've been talking about bronchial asthma, people that have bronchospasm and inflammation, cough, wheeze, shortness of breath, reliever medicines. You need to know how to use them, and controller medications. Sometimes there's a combination of the two. The medicines are so good that we should be able to give people adequate relief. Remember, if the sinuses are not happy, the lungs are not happy. So you can't forget those in the treatment. That a pretty good summary?
Absolutely.
So let's talk about some of the newer treatments that we've got in asthma. Since there are different types that you say, we use the word phenotype. It's sort of a new word to me. What does that mean, phenotype?
Kind of a new word in asthma. We're learning there's different phenotypes. So phenotype is, the best way to think of that is like a face, okay? We all have different faces, different genetic makeup, but there's some environmental factors that influence that face. And in our case, a cruel gene that made our hair fall out. But
all that doesn't cause asthma, does it?
Lots of other things, but not asthma. So if we know your phenotype, that may influence, well, I may use this medicine, or you might respond better to this and not that. So we're getting a feel for phenotypes, but it's not something your doctor will necessarily talk to you about yet. But it is a very active area in asthma, and we're looking at phenotypes, trying to find out what makes up a phenotype, what inflammatory pathway drives that, so we can pick better medicines for you as an individual rather than as the whole population of asthmatics.
Do we have specific medicines for specific inflammatory pathways you mentioned?
Yeah, so in the past we've had anti-inflammatory medicines that were rather non-specific, like that foundation, that cornerstone drug, the inhaled steroid. It works, but it just kind of blanketly hits a number of things. Well, now we have anti-inflammatory medicines or biologics, monoclonal antibodies, which target unique aspects of the immune system.
Give me an example of one. Let's talk about the inflammation. That means there's different cells causing problems. What is one of those cells that you think of that causes problems and inflammation?
Yeah, so, well, the eosinophil would be one of the main cells, but it's kind of interesting. We see a lot of stuff. We see lymphocytes, neutrophils, epithelial cells that are not just epithelial cells. They do a lot of things to promote this inflammation and symptoms as well.
So we've got newer medicines that could go after the different type of cell types. For instance, the eosinophil. What are some medicines that are available? If somebody's got asthma, and that means they're on a reliever and a controller, but their asthma is still causing trouble, what do you do about the eosinophil inflammation?
Yeah, so that's that kind of severe persistent asthmatic. It's a minimal part of the population, but they are the ones that are in your office the most, in the emergency room the most, the hospital the most, use up healthcare dollars for asthma therapy. And we've not had great therapies. We always gave them oral prednisone, but it just didn't always work. So now we know the eosinophil, and we know some of those patients have elevated eosinophil levels. And there are two drugs we use. Both of them, though, focus on IL-5, which is important in recruiting and promoting eosinophilic inflammation. So that monoclonal antibody will bind to that and remove that drive for that eosinophilic inflammation.
So if we can take away the eosinophil, we take away part of the inflammation, it makes the lungs less twitchy, less swollen, less difficult, and the person with severe persistent asthma may have a good chance of getting better.
Absolutely.
So these new medicines that are against IL-5, we said, and the IL-5 brings on eosinophils?
Yes.
So how do we give those medicines? Are they usually by shot? Or
one of them is by shot, and another one is intravenously. There's some nuances to the two, and patients make individual decisions, but either one of those would be a good choice for that eosinophilic inflammation.
So we have to get a blood count looking for eosinophils or sputum examination to find that out.
Sure.
Talk to me about sinus surgery. I've seen some patients that was the key to their asthma getting better. Why is that? Tell me about sinus surgery.
So there are a lot of patients with asthma, and in fact, this is my experience with asthmatic patients. You have to really dig and ask them about the sinuses because they're so focused on the lungs. That's understandably, I can't breathe. I don't care about my nose and sinuses. But once you start talking to them, and if you go looking for it, I have a low threshold to get an x-ray of the sinus or a CAT scan of the sinus because I'll find often severe sinus disease or polyp disease, and that is part of this inflammatory pathway. There's also the aspirin-sensitive asthmatics.
Now what is that?
Those are patients who, if they take aspirin or other non-steroidal drugs, will get itchy eyes, sneezing, congestion, and asthma symptoms.
So that's a very, very serious thing. Those are usually people with polyps?
Polyps, yes.
So we've got aspirin-sensitive people, we've got sinus disease. Does sinus surgery, or you just have to treat with nose sprays? Like?
Well, you can try medical therapy first, but there's a lot of those patients that fail medical therapy and need surgical therapy and then back on medical therapy. But there's no doubt that if we get those sinuses controlled, they do much better. If we get their polyps controlled, if we get them desensitized to aspirin, big difference in their sinus disease, almost night and day in some of them, if not most of them, and then their asthma control improves as well.
Sinus surgery, how does it help the sinus disease?
Sinus surgery improves ventilation and drainage.
So lets the air get into the sinuses and lets the sinuses drain.
Correct. And if it can ventilate and drain, it doesn't tend to have all those inflammatory changes and infections that we see.
Allergy skin testing, you mentioned to find out some of the driving triggers of asthma. Does allergy desensitizing help asthma sometimes?
Absolutely. So if you look at what is the largest predisposing factor to asthma? It's allergies, okay? So people with allergic rhinitis, children with allergies, those are the ones that are highest risk to develop asthma. So if they're the highest risk to develop asthma, controlling that allergic disease with avoidance, with good medications, and with immunotherapy is a great way to improve their asthma control. And in fact, in children, there's a growing body of evidence that allergen immunotherapy or desensitization to those allergens will decrease their risk of asthma persisting into adulthood. This is the first thing in my scope of practice where you have the chance of taking away their asthma.
And that's a beautiful thing to be able to do. If you've got somebody having trouble at an early age, to be able to start treatment that makes it where they may not have chronic asthma later on. A couple of other things. Number one, bronchial thermoplasty. Now, what is that and when is that ever indicated?
So we start thinking, so if you have a moderate, severe persistent asthma on good medications, but yet they're frequently in the office, flared up, they're in the emergency room, they're hospitalized, you have to start thinking, okay, what else can I do? And we talked about anti-IL-5, there are some other monoclonal antibodies for other things, IgE, a thing called Xolair, but there's another thing we have that's not a medication. It's not a monoclonal antibody, it's bronchial thermoplasty. So it's where you take a bronchoscope and you put the patient to sleep, general anesthesia, go into the lung, and we induce a thermal injury, which doesn't do anything for the inflammation as much as it does the smooth muscle cells. We got these big muscular smooth muscle cells. Well, we don't really need big muscular smooth muscle cells. And what it does is it injures those, and so they're not as potent when they constrict, and so we have less exacerbations. It doesn't come without a risk. There's a significant increased risk of an asthma exacerbation peri-procedure, and some of those patients get hospitalized after the procedure. It's multiple procedures. It's a bronchoscopy. There's certainly some cost associated with it. I've seen really good responses to it, and I've seen some that didn't. So that's another one. We need the phenotype that responds best, the face that responds best to bronchial thermoplasty.
So what I'm hearing you say basically is the worse the asthma gets, the more medicines and types of treatment we have to get the patient better that we didn't have too many years ago. So if somebody's got chronic asthma, coughing, wheezing in the emergency room, in the doctor's office frequently, know that there are medicines for them. Phil Jones, you're a great teacher.
Thank you.
Thank you for coming to the Dr. Bob Show and telling us that if you have severe asthma, there's treatment out there that can get you better and keep you out of the hospital.
Thank you. I always enjoy coming down.
Wasn't that great information? You're going to want to stay tuned. We're going to be talking about dementia. What can we do to keep from getting dementia, Alzheimer's, vascular dementia, and who needs a flu shot? Do people really need a flu shot? You'll want to know the answer to that. I want to thank Dr. Phil Jones. Wonderful discussion on new advances and new treatment for bronchial asthma. And now questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, is there any way I can prevent from getting dementia? Well, we know dementia is where the brain doesn't work good. We don't think well. We get problems processing time and problems that we have. And eventually, if we have Alzheimer's, it's a progressive neurodegenerative disease. Huge problem. And more people will be getting dementia and Alzheimer's as time goes on. So as we look at patients with Alzheimer's, what can we do to prevent that? Well, really the same things that we talk about for preventing heart disease and blood vessel disease. So if we eat properly, there's less chance that we'll get dementia. If we exercise frequently, there's less chances that we'll get dementia. If we exercise our brain, it slows down the onset of getting dementia. A recent announcement from the American Heart Association states that people that have high blood pressure in midlife have a greater chance of having dementia. So what can we do about that? In midlife, whatever that word means, let's say age 40 to 55 or 40 to 60, know what your blood pressure is. Normal value is 120/80. If your blood pressure is high, work on getting your blood pressure down to normal. It may mean lifestyle changes such as exercise, eating less salt, eating properly, getting better sleep, or it could be that you'll need medications to take that lower your blood pressure so that there'll be a less chance that you'll have dementia later on. Next question. Dr. Bob, I'm afraid of the flu shot. Who really needs the flu shot? It's a good question. The flu shot, influenza, changes its personality every year. And so the flu shot that works one year may not work the next year. Anybody over 6 months of age, up to when they die, should have a flu shot. Well, what happens if they don't get a flu shot? If they get the flu, they'll have a difficult time surviving, living, if they've got heart disease, if they've got asthma, if they've got some immune problems that they already have. So if you're already chronically ill and the flu gets on top of that, then your chances of living go down significantly. Also, if you get your flu shot, that keeps you from getting the flu and transmitting that to somebody else that's sick. So we also think of other people. In the last couple of years, we haven't used the flu mist, the nasal spray, because it's a live virus, and we can actually get some problems with the flu with that. The flu shot is with a killed virus, and so we don't get the flu from the flu shot. You may get some soreness in your arm from the protein, but you won't get the flu from that. So our recommendations are is that everybody get the flu shot. If you think you've got a severe egg allergy or you've had problems with the flu shot before, you have to talk that over with your doctor and get a plan that would be specifically for you. It's all the time that we have for this show. Remember those 4 things. Remember how important exercise is. It'll help you from getting dementia. It will improve your heart. It will lower your cholesterol. It will make your blood pressure better. It will make you feel better. There's a runner's high. When you run and when you exercise, you'll feel better. Eat properly. Eat more fruit, more vegetables, more fiber. Less fatty foods, less fried foods. Less volume of foods. If you need to lose weight, be sure you fuel the fire by eating regular, but eat smaller amounts. 7.5 hours sleep. How important that is to everybody. If you get a good night's sleep, you're going to be more productive the next day. You'll be happier the next day. You won't be so temperamental. And so be sure that you're getting your 7.5 hours sleep. If you don't sleep well, you may have to talk it over with your doctor and figure out if it's medications or if it's pain or if it's something that keeps you from sleeping well. And most of all, what is it we like on the Dr. Bob Show? It's that giggling and that's laughter in your life. If you laugh a lot, you'll stay healthy.